इसमें एक्चुअली सर शेयर का ऑप्शन ही आ रहा है।
मिस्टर सुशील सर को को होस्ट कर दो।
को होस्ट बनाया हुआ है आकाश को। आकाश तुम को होस्ट हो।
नीचे ग्रीन बटन आ रहा होगा।
नहीं सर, नहीं आ रहा है। फिर से ज्वाइन करके देखता हूँ सर।
हाँ, दोबारा। आपने अपना ईमेल पे लॉगिन किया हुआ है उसमें?
अपना डॉक्टर आकाश, जो आपको मैंने कल लिंक भेजा ना व्हाट्सएप पे, पैनलिस्ट वाला, उससे ज्वाइन करो।
और
वैसे तो
दूसरा
आप
ना,
कोर्स
जूम पे
नजर
भी
आ रहे
आप
हो।
लॉगिन रखो अपना मेल आईडी से।
आप तो कोर्स तो नजर आ रहे हो, इसमें कोर्स लिखा हुआ है।
मिस्टर सुशील एक बार को होस्ट कर देना मेरे को भी।
मैं करता हूँ। आप बन गए हो को होस्ट अजय।
थैंक यू। डॉक्टर आकाश एक बार आप ट्राई कर लो, स्क्रीन शेयर आ रहा है उसमें बटन। नीचे ग्रीन बटन आ रहा।
आ गया सर, आ गया।
ओके,
ठीक है, ठीक है। That should be done in all, I see. आप लोग ने क्या क्वेश्चन के साथ में? अच्छा, अब मुझे बताओ आपकी टोटल फुल टाइम कंसल्टेंट्स की फाइनल लिस्ट जो आपने अपलोड करी कितने?
5 मिनट आता हूँ।
दैट्स ग्रेट। डॉक्टर आकाश एक बार स्टॉप कर दीजिए।
हाँ
तो फाइन।
साउंड में इको तो नहीं हो रहा सर?
नहीं नहीं, वो आप शायद दो डिवाइसेस से ज्वाइन है। हाँ अब ठीक है। So, good morning, respected faculty, Dr. Pankaj, Dr. Akash, Dr. Prashant, Dr. Naveen, and dear delegates. It's 9 o'clock, and we are again here with the next session on eNeonatology, that is hematology of neonate. Dr. Pankaj will be chairing this session, and along with the chairpersons, Dr. Naveen Gupta and Prashant Karia. I request Dr. Pankaj Garg to please carry on the session and introduce the chairpersons.
Good morning, friends. So we are here with you another session of eNeo course. As you know, this course is for office-based pediatricians, and this is our 6th session in progress. So we have been discussing each session topics which are very pertinent for a pediatrician, and they have to do neonatology on day-to-day basis. So today's session is very interesting. We are going to interpret the complete blood count or hematology of a newborn with the help of Dr. Akash Pandita. But first, let me introduce the chairpersons for the day. We have two chairpersons today. We have Dr. Naveen Gupta. Dr. Naveen Gupta is a great friend. He has been a constant source of inspiration for many of us who are interested in doing focus and functional echoes. He is trained from Gangaram Hospital. He did his DNB from us, and then he did overseas fellowship from Vancouver, Canada. So he has been the lead consultant at Rainbow Children Hospital, Delhi, and they also started the DNB neonatology course for last, I think, 2 years or so. That's a great beginning from Dr. Naveen Gupta. So I welcome Dr. Naveen Gupta to the forum. Another chairperson is Dr. Prashant V. Karia. Dr. Prashant Karia is a very important CIP member. He is an executive board member of CIP from Gujarat, Surat. And he's a very active member, and you can see his name in a lot of activities which CIP does, whether it is Man Ki Baat or what is called Kaam Ki Baat from our Community Ke Saath, which is a president action plan for this year by Dr.
IP के
Basavaraj.
बाद community के साथ social messages from
right. And he's active member of many of the committees of CIEP. So I welcome Dr. Prashant also to this show. So first, I will request Dr. Prashant to say a few words about the role of office-based pediatrician and how they are perplexed with hematology of a newborn. And then I request Dr. Naveen to introduce us, Akash. First to Dr. Prashant.
Thank you so much, sir. First of all, thank you so much for inviting me to this as a chairperson. I'm sure Dr. AKASH Pandita is going to talk a lot about the hematology in neonates. But as a common pediatrician, what we usually see is there are so many different things. The hematological parameters in neonates are different. I mean, they do have a high hemoglobin. Sometimes they are having anemia, sometimes they are having a polycythemia, sometimes they are having a thrombocytopenia. Even the HbF, which is high at birth, or some genetic disorders which can be picked up at birth, even due to a high hemoglobin, there is high chance of a jaundice. All these things are different in a newborns, and I'm sure that Dr. Akash is going to cover. So, not taking much of a time, just saying that hematological parameters of neonates are much more different than the children, and that should be interpreted differently. So, thank you so much.
Thank you, Dr. Prashant. I request Dr. Naveen to introduce Dr. Akash Pandita.
Great. Thank you, sir. Thank you, Dr. Pankaj, for inviting me as a chairperson to chair this talk and a very, very important and relevant and pertinent course run by the Indian Academy of Pediatrics. And so it's a pleasure to introduce Dr. Akash. Dr. Akash is a dear friend. He has done his DRNP in neonatology, and presently he is the Director of Neonatology and Development Care at Medanta Hospital, Lucknow. And he is holding the position of Vice President, the Neonatology Foundation, Lucknow. And he has many publications to his name, and he's a reputed author and reputed reviewer, many reviewer to many international journals. And I think at such a young age, so many publications are great credit to him. And we are looking forward to a great talk on neonatal hematology by Dr. Akash. Over to you, Dr. Akash.
Thank you, Naveen sir, for that kind introduction, and thanks to IAP Delhi and Pankaj sir for giving me this opportunity to be among the August gathering. I have tried to do my justice because neonatal hematology is something which we are not taught commonly, but it's a very vast subject. So I have tried to capture some of the clinically important highlights among the neonatal hematology. I hope it should be useful for all. So coming to this topic, in the next 30 to 40 minutes, we'll be talking about approach to a case of neonatal anemia, different transfusion cutoffs, because giving platelet PRBC transfusion is one of the commonest intervention or one of the commonest procedure which we do in our NICUs. Although there are no evidence-based guidelines, but there are certain guidelines which one has to follow. And finally, I will talk about neonatal thrombosis, which we see both venous as well as arterial in NICUs, and it sometimes is quite challenging to treat such babies. So as we all know that anemia and thrombocytopenia are quite common, especially in sick newborns who get admitted in our NICUs. And almost 50% of the babies who get admitted, they receive some form of transfusion. And the rate is as high as 90% in ALBW babies. That is, ALBW babies at least receive one transfusion during their admission. And although it's so common to give blood products in NICUs, but still there is no evidence-based consensus. Whatever little evidence is there, it is mostly expert opinion. But overall, the evidence favors that restrictive policy is better than a liberal one. First, we'll be coming to the RBCs, that is the red blood cells. Just a background about reticulocytes. So basically, reticulocytes are immature red blood cells which contain RNA and organelles in a reticular pattern. That's why they are called reticulocytes. They usually have a half-life of 1 day before they get matured into mature RBCs. And usually, high retic count indicates either hemolysis or hemorrhage. Since RBCs have a half-life of 120 days, the retic count is usually calculated as a percentage, and normal percentage comes out to be 0.8, 0.9. Now, the problem with reticulocyte count is that it is dependent on the hematocrit or hemoglobin. So, in cases of anemia or neonatal anemia, we can get a false high reticulocyte count, although the marrow is suppressed or is not giving an appropriate response. Therefore, we need to know the absolute reticulocyte count. The advantage with absolute reticulocyte count is that it gives us the number of the new RBCs produced in the last 24 hours, and it overcomes the inherent pitfall which is there in the reticulocyte count, because it also takes into account the RBC count. Absolute reticulocyte count is calculated as percent of reticulocytes multiplied by RBC counts. And there is also something known as corrected reticulocyte count, which is very important in evaluating neonatal anemia, because if the reticulocyte count is high, we know that the cause can either be hemorrhage or hemolysis. On the other hand, if absolute reticulocyte count is low, it indicates that there is a marrow failure. And if the corrected reticulocyte count is less than 2%, it is indicative of hypocellular marrow. Now, neonatal anemia is quite common, and it usually presents in the form of poor weight gain, tachycardia, tachypnea, increased oxygen requirement. And one thing which is very important in CBC to diagnose acute versus chronic hemorrhages, whenever there is hemorrhages chronic, for example, fetal-maternal blood loss or hemoglobinopathies, the RBCs become microstick. So on CBC, if we see a microstick and we have to differentiate between acute hemorrhage and chronic hemorrhage, always look for microcytic anemia, which is indicative of chronic hemorrhage. And in cases of severe anemia like HBH disease, the manifestation can be as severe as hydrops vitalis. What is important is that whenever we are evaluating anemia or any blood disorder, it's always important to send a sample or to preserve a sample before giving a transfusion. Otherwise, if we send samples post-transfusion, the results can be erroneous and it will not lead us to any conclusion. The common sampling for a neonatal anemia includes a CBC, red T count, peripheral blood film, blood group, of course, and the DCT. Now, some of the markers which indicate that the cause is hemolysis include, whenever there will be hemolysis, there will be rise in indirect bilirubin and a fall in hemoglobin. Also, we discussed that whenever there is hemolysis, the red T count will increase in order to compensate for that increased destruction of RBCs. Now, hemolysis can be either immune-mediated or non-immune-mediated. And the simple test to differentiate between immune versus non-immune hemolysis is doing a DCT, which if is positive, it signifies that it is a immune-mediated hemolysis. And whenever we examine these babies, apart from the anemia, we'll also find hepatosplenomegaly. Now, a word about sometimes, because now NTD is quite commonly used in cases of Rh negative pregnancies, but we have to remember that in 3 to 6% of the cases, this NTD can cross the placenta and can give a false DCT positive, even in the absence of hemolysis. So whenever we see any baby with anemia, we have to first do the absolute retic count or the corrected retic count. If the retic count is decreased, it tells us that there is a marrow failure. In premature babies, the most common cause of marrow failure is anemia of prematurity. The other causes includes Rh incompatibility, where we see a chronic anemia, or it can be very rarely. If the anemia is persistent without any cause, always look for congenital hypoplastic marrow syndromes like diamond black fun. On the other hand, if retic count is increases, it shows that either there is hemorrhage or hemolysis. Now, the hemolysis, as we discussed, can be either immune-mediated and non-immune-mediated. And the simple test is DCT. If the DCT is positive, we have diagnosed that it is an immune-mediated hemolysis, apart from clinical clues of hemolysis, which includes jaundice, hepatosplenomegaly. The common causes of immune-mediated hemolysis in neonatology is major blood group incompatibility, like Rh and ABO, and very less commonly we see minor blood group incompatibilities. However, if DCT is negative, we have to look at the CBC picture, that is whether the anemia is microstick or normostick or microstick. We discussed that if the anemia is microstick, that is the CBC showing microstick anemia, either it can be chronic blood loss, which can happen in twin-to-twin transfusion or fetal-maternal hemorrhage, or it can be suggestive of hemoglobinopathies like thalassemia, like alpha and gamma. Usually, we all know that since there is a high percentage of fetal hemoglobin in neonates, so beta thalassemia usually does not present in neonatal period. However, if the CB is suggestive of normostick or macrostick, then we have to look at the shape of the red blood cells. And if it is spherocytes leptocytosis, it gives us the diagnosis that it is either hereditary spherocytosis or leptocytosis. However, if it is normostic and peripheral smear is normal, we have to rule out hemolysis, which can be either because of the enzyme deficiencies like G6PD, which is more common, and less commonly pyruvate kinase or hexokinase. Also, the infections, either viral or bacterial, can sometimes lead to hemolysis. Now, we should also know when to transfuse. As we already discussed that there are no clear evidence-based guidelines, but usually what we follow, or according to our NNF and IAP guidelines, for first 24 hours in stable baby, we follow a cutoff of 10, and for babies who are on uneased respiratory support, usually we try to maintain a hematocrit of 35 or more. Subsequently, as the baby becomes more mature, the threshold becomes low. Now, there are some other markers which can help us decide whether we should transfuse or not. One of them is serum lactate. We know that whenever there is anemia, there is decreased oxygen supply to the tissues, which leads to anaerobic metabolism, leading to increased lactate production. However, we should also keep in mind that lactate is not a specific marker for tissue hypoxia. Lactate can also be increased in sepsis or other conditions. Therefore, it is not a specific marker, but can be taken into consideration before we decide whether to transfuse or not. The other thing which has helped us in giving transfusion is NIRS. Although initially NIRS gave some positive results, but it is still, the values are so variable that still it has not found its place in day-to-day neonatal practice. And one should always take the clinical condition into account while deciding whether or not to give the transfusion. For term babies, for stable babies, we can maintain hematocrit up to 21%, and usually if the baby is asymptomatic, we can monitor these babies on OPD basis. However, if the baby is on any respiratory support, for example, he's on oxygen but with an FiO2 of less than 35%, or he's requiring some form of respiratory support like CPAP or an IPPV, but the MAP is less than 6, in those babies, we tend to maintain a hematocrit above 30. If he's on higher support, that is a MAP of more than 6 on an IPPV, then we tend to maintain a hematocrit of more than 35%. For babies with congenital heart disease or requiring ECMO, we try to maintain more than 45% because those babies, the blood is not completely saturated, and therefore we try to maintain a higher hematocrit in order to avoid tissue hypoxia. These are some of the other guidelines which are international guidelines, and this is just for the reference. We usually follow the previous guidelines. Now, the general principles while giving transfusion is that usually we give 10 to 15 ml per kg of PRBCs over 3 to 4 hours. We give over 4 hours. Smaller the baby, usually the duration should be on the longer side. And irradiation of PRBC is highly recommended to prevent graft versus host disease. And in preterm babies during transfusion, it is advisable to keep them nil per oral because of the risk of transfusion associated NEC. Coming to the platelets, again, thrombocytopenia is quite common, especially in country like ours, where the incidence of sepsis is as high as 10 per thousand live births. Although it is one of the commonest intervention which we do, but majority of the platelet transfusion in our practice are actually prophylactic. And because there is always a fear among the clinicians that baby may bleed. But the evidence has shown that there is hardly any correlation between the platelet count and the actual risk of bleeding. Babies who have less than 50,000 platelets, only 10% or 5 to 10% of the babies actually have a significant bleeding. To know the cause, usually we broadly classify thrombocytopenia into early onset and late onset. That is, before 72 hours, we classify it as early onset thrombocytopenia. And if it occurs after 3 days of life, we call it late thrombocytopenia. In majority of the healthy babies, especially the preterm babies, the cause of early onset thrombocytopenia is placental insufficiency. That is, mother who has chronic hypertension, preeclampsia, or a baby's IUGR. Mostly this type of thrombocytopenia is not severe. The platelet count hardly goes below 80,000. And usually the babies are otherwise fine, stable. There is no evidence of bleeding. And there is a spontaneous recovery by the end of the first week. Now, when should we investigate in early onset thrombocytopenia? If baby is sick, the thrombocytopenia is very severe. That is, the platelet count is below 50,000. In those babies, if the baby is otherwise well, but the platelet count is 50,000, in a term well baby, we need to rule out NEIT, that is neonatal alloimmune thrombocytopenia. Whereas in sick babies, the most important cause is HIE. It has been seen that around 30% of the HIE babies can have severe thrombocytopenia secondary to marrow suppression, and it can be prolonged and severe. Late onset thrombocytopenia is very common in our setting because of the high incidence of sepsis, and the two most common causes include sepsis and NEC. And often the late onset thrombocytopenia is often associated with DIC. So always it is better whenever there is a baby with late onset thrombocytopenia, you should always do a coagulation profile to rule out DIC and prevent bleeding. Sometimes this thrombocytopenia is often protected. That is, even if you have treated sepsis, the platelet count tends to be low. So you don't need to chase these low platelet count if you have corrected the sepsis babies otherwise well. You don't need to chase the platelet count with antibiotics. If you have given adequate dosage, baby has responded, he is otherwise clinical stable. Majority of the times, whenever you follow up these babies, they will recover. That is, the platelet count will recover. Do not continue antibiotic just for the sake of that the platelet count is low. Now, as we discussed that in a stable term baby, one of the commonest causes of severe thrombocytopenia is neonatal alloimmune thrombocytopenia. It is usually because of the maternal sensitization to paternally derived fetal platelet antigens, because of which the mother develops antibodies and they are passed on to fetus. The problem with this type of thrombocytopenia, it can be very severe and it can have a dreaded complication of intracranial hemorrhage to the tune of 20%. And majority of, that is 80% of these intracranial hemorrhage can happen in utero as early as 20 weeks of gestation. Therefore, we have to be very vigilant in monitoring these babies. They may be completely asymptomatic. They may have a severe IVH leading to seizures, bulging fontanella, or there may be petechiae only. The management includes that such babies, first of all, should be regularly monitored. We need to get a scan done on day 1 of life and day 3, day 4, because at day 3, day 4, there is a max, that is the nadir occurs, whereas the platelet touches the bottom. So we need to do one scan at 4 times and one before the discharge. You need to ensure that these babies are monitored till there is recovery of the platelet count to near normal, and which usually happens towards the end of the first week. We usually give platelet transfusion whenever the platelet count goes below 25 to 30,000 with the compatible platelets. And if the thrombocytopenia is prolonged, that is, we have to give repeated platelet transfusion, then it is better to give IVIG, which decreases the need for subsequent platelet transfusion in the dose of 1 gram per kg for 2 days. The other common causes of thrombocytopenia in otherwise well-term babies is neonatal autoimmune thrombocytopenia, which is because of the maternal antibodies, either because of the maternal ITP or autoimmune syndromes like SLE. Usually, the severe thrombocytopenia is less common in this form of thrombocytopenia. Also, the good thing is that the incidence of ICH is low. However, this type of thrombocytopenia may persist for months, and whenever the thrombocytopenia is severe, that is platelet count is less than 30,000, we usually treat with IVIG first, that is 1 gram per kg for 2 days, followed by platelet transfusion. The other less common causes of thrombocytopenia includes congenital infection. In those babies, you have to look at other markers of intrauterine infections, which includes IUGR, abnormal eye examination, intracranial calcifications, dysmorphism, hepatosplenomegaly. Similarly, some syndromes, especially the trisomies 13, 18, 21, apart from the common dysmorphism which we see, they can have severe thrombocytopenia. Inherited thrombocytopenia should be suspected whenever the onset is early, that is during the first few days of life, and the thrombocytopenia persists beyond 7 to 10 days without any obvious cause. But the common causes include TAR syndrome, that is thrombocytopenia with absent radius, Diamond-Blackfan syndrome. Now coming to the approach, so whenever there is early onset thrombocytopenia, if the baby is preterm and otherwise stable, the commonest cause is placental insufficiency. We don't have to do anything, just monitor them. Usually they recover by day 5 to day 7. If the baby is a term baby and otherwise well with severe thrombocytopenia, think of 2 causes. One is NEIT, that is neonatal alloimmune thrombocytopenia. Remember to rule out ICH, that is intracranial hemorrhage, and monitor these babies till they have a normal platelet recovery. The other Common causes autoimmune thrombocytopenia, which is because of the maternal SLE or maternal ITP. If the thrombocytopenia is early and the baby is sick, then look for intrauterine infections, sepsis, and chromosomal anomalies. Late onset thrombocytopenia, the baby is usually sick and is often secondary to sepsis, which may be either bacterial or fungal, and NECs. Now, whenever there is a bacterial infection, the baby usually crashes like anything. But the fungal babies are more stable. They tend to have hypo and hyperglycemia, and thrombocytopenia is usually more prolonged. In late onset thrombocytopenia, if the baby is well, usually it is because of the thrombosis, which is often secondary to the catheter like PICC line, umbilical line, or medications. The common medications which cause thrombocytopenia includes our antibiotics, which we try to give to bring the platelet counts normal, or NSAIDs. Like reticulocyte count in anemia, the mean platelet volume is important in finding the cause for thrombocytopenia. Now, if the mean platelet volume is normal, it shows us that the thrombocytopenia is because of the decreased production. However, if the mean platelet volume is increased, it tells us it is because of the accelerated destruction, for example, which happens in sepsis and NEC. So for platelet transfusion cutoff, if the baby is otherwise stable without any evidence of bleeding, we tend to keep the platelets above 25,000. However, if the baby is having active bleeding or baby with NAT with previous sibling having a history of intracranial hemorrhage, we tend to maintain platelet count above 50,000. For any major surgery or procedure, the platelet count has to be maintained above 1 lakh. For CSF examination, we usually tend to maintain a platelet count above 50,000. These are some other international guidelines for platelet transfusions. Coming to the other blood product, which we again commonly use in our NICUs, is fresh frozen plasma. Now, the fresh frozen plasma contains almost all coagulation factors, including the labile factors, such as factor 5 and 8. Usually, we tend to give FFP more as a prophylactic, which is not a correct thing, but we should usually give if the INR is more than 2, or PT or APT is more than 1.5 times the normal range, depending on the lab you are using. Also, rarely we use FFPs to treat congenital deficiency of some clotting factors if we do not have those specific factors available at that time. It is also used for treatment of DIC. Now, the dose is again the same, for example, as in PRBCs, that is 10 to 15 ml per kg, and it usually corrects the coagulation factors by 15 to 20%. What is important to remember that the effect of an FFP lasts for 6 to 12 hours. So it is time bound. So accordingly, you should give transfusion. For example, before procedure, before surgery, if you have to give, you should have to time the FFP transfusion. Another important thing to remember in FFP transfusion is that we use straight as an anticoagulant for plasma. So if you are giving rapid plasma, that is at the rate of more than 1 ml per kg per minute, it may be associated with citrate toxicity. Now, citrate itself can cause myocardial depression, hypotension, and abnormal coagulation. So you have to keep that in mind, that always give FFP slowly, not more than 1 ml per kg per minute. I've heard about neonatal thrombosis, although it is rare, but we do often see cases of neonatal thrombosis, both venous as well as arterial. The most common important risk factor for arterial thrombosis in neonates is indwelling catheter, like PICC line, central line, or umbilical catheters. Whereas in venous thrombosis, it is often secondary to sepsis, hypovolemia, or dehydration. Now, the neonate is inherently predisposed to thrombosis. That is, neonatal period is a prothrombotic state, because we all know that our neonates have a higher hemoglobin, which causes increased viscosity of the blood, therefore more likely of thrombosis. The vessels are very narrow, especially when we compare it to the catheters which we use. So again, it leads to increased risk of thrombosis. Also, the neonates have low levels of proteins that are important in coagulation regulation and fibrinolysis. Some of the risk factors which predispose our neonates to thrombosis include asphyxia, sepsis, dehydration, and maternal diabetes. Renal vein thrombosis is something which is very common in babies born to infants with diabetes mother. Apart from these, there can be some inherent causes of thrombosis as listed here. Now, when should we investigate? Every case of thrombosis does not need to be investigated. We should only investigate if the thrombosis is very severe, unusual, or there is very extensive venous thrombosis, or there are very severe skin lesions, including purpura fulminans. In those cases, we need to send a complete thrombotic panel, which includes protein C, S, and antithrombin levels. However, we have to remember that quite often we come to babies come that the mother has history of thrombophilia and they come for testing. Remember that thrombophilia is rarely present in the neonatal period. So we do not have to investigate unless and until baby has symptoms suggestive of homozygous state. Otherwise, we don't need to investigate for thrombotic disorder during neonatal period. Same is true for factor 5 Leiden mutation or prothrombin gene mutation. Again, these disorders do not present in the neonatal period. Again, if the mother has these mutations, we do not need to investigate during the neonatal period. Coming to the treatment, if it is in secondary to central line, we have to keep in mind that do not remove the central line immediately because it can lead to the dislodgement of thrombus and can cause severe problems, including pulmonary thrombosis. So it should always, the catheter which is linked to thrombosis should always be removed 3 to 5 days after anticoagulation. For anticoagulation, we usually prefer low molecular weight heparin. Warfarin is not recommended during neonatal period. And always babies on heparin should be monitored for platelet count and anticoagulation. The duration usually is 6 weeks to 3 months, depending on the response. And usually thrombolysis is given only if we have an end organ dysfunction or one limb is at danger. Otherwise, we do not use routine thrombolysis in neonatal practice. Now, why do we prefer low molecular weight heparins? Is because there is less risk of hemorrhage with low molecular heparin. We can give it by subcutaneous route, so we do not need an IVSS. It decreases, it has got less risk of bleeding, so the monitoring is not too cumbersome, and there is also less risk of thrombocytopenia. The only disadvantage with low molecular weight heparin is that it has got a longer half-life compared to unfractionated. So in cases where you have to give short-term thrombolysis, for example, patient has to undergo surgery. In those cases, we can use unfractionated heparin. Otherwise, low molecular heparin is the modality of choice. The take-home messages includes that blood products should be used judiciously. They are associated with the complications, and there is no role of prophylactic, either platelet transfusion, PRBs transfusion, or plasma. Whenever you are giving these blood products, they are associated with some inherent risk factors, including infection, which can be life-threatening. So always monitor these babies and ensure that you have guidelines in place for your unit, and we should be followed strictly. Thank you.
Thank you, Dr. Akash, for such an enlightening presentation. So there is a question in the chat box. Mr. Akash is asking, what are the normal MCH values for the neonate?
We have a chart for that. I will share that in the group.
Akash, please stop sharing your screen.
I will share the nomograms both for for MCBs as well as for the normal hemoglobin levels in the group.
We also welcome Dr. Ravi. He is the coordinator for this eNeurology course. Welcome, Dr. Ravi.
Hello.
Yeah, Dr. Ravi, hi.
Hello. How are you?
Good, Dr. Ravi.
Okay. Thanks, Dr. Dr. Akash, for such a beautiful and lucid presentation. So, can anybody see the questions? I could only see a few questions there. So,
Yeah. So,
yeah, Dr. Naveen, please go ahead.
So, Dr. Akash, Dr. Amit Suyal is asking, sir, how to confirm if the ABO incompatibility is the cause of exaggerated jaundice and what blood to give if exchange transfusion is also needed?
So always whenever there is any jaundice, we always first of all confirm the blood group of the mother. So if the mother is O and baby is AB, so that should be the first pointer towards that ABO incompatibility. Usually, unlike RH, in ABO, it can happen. It can either increase in severity or be the same in subsequent pregnancies. Other thing is DCT. Although DCT is not always positive in ABO incompatibility, but if the DCT is positive, it is again telling us that it is because of the ABO incompatibility. And similarly, look for the features of hemolysis on examination, that is rise in unconjugated bilirubin if there is no other cause for jaundice, hepatosplenomegaly. And whenever you do a CBC, spherocytosis on the CBC.
Yeah, and the other question is, suppose the child needs exchange transfusion, which blood to give? Suppose mother is O positive and baby is A positive or B positive. Dr. Akash?
Hello?
Muted, I think. Yeah. Now we can hear you.
Hello?
Hello, Dr. Akash, are you able to
Hello?
hear us?
Is there, Akash? You can see him.
Hello?
Yeah, Akash is there, but Akash is, I think he's not able to hear us.
Hello?
Hello, can you hear me, Akash?
आकाश दोबारा लॉग इन कर लो. हाँ.
Hello? Hello?
डॉक्टर रवि बाकी क्वेश्चंस आप ले लो.
Okay. So the second question is asked by the Dr. Nilima.
डॉक्टर आकाश है नहीं अभी. लेट हिम कम बैक. हाँ.
Okay, sure. So normal WBC range in neonate. So it is asked by Dr. Nilima. So Dr. Nilima, as far as the WBC range is concerned, for term and preterm, and the more the preterm baby, more will be the range. If you take it as a cord blood, a total count, so it can range, as high as 35,000 and and once it is more towards the term baby, it falls, and after 1 week it takes usually the nadir. So it depends upon the how you are going to interpret it, whether it is a term baby or preterm baby. And in fact, among the preterm baby, the 36-weeker baby will have a different total count, and the 26-weeker baby will have a different total count. So it basically it is the normogram which are there in the books, on the we can exactly.
So maybe it's a good idea to stick on some board somewhere in your system, because it's very difficult to remember all that.
Exactly.
So Nilima, Monroe curve can be used for the term baby and Mosino for the preterm baby, in addition to what Dr. Ravi has already stated. So you can use that. Dr. Ravi, the next question is, what is the normal pattern of HB fall in the neonatal period?
Okay, the same applies to for the hemoglobin also. If you take it as a cord blood, for a preterm baby, it can be as high as 18 or 19 or 20. But if we come to the the full term baby, it may be ranging from near about 15. So it also nadir actually falls, and towards the more maturity, the hemoglobin level falls. So this is how it is to be interpreted.
Yeah. Just to add to it, Dr. Manoj, so what happens is the hemoglobin keeps on falling till the time there is sufficient hypoxia which stimulates the bone marrow, right? So normally, and then the HB production starts. Normally in term baby, the nadir comes around 10 or 11, and then the hemoglobin synthesis starts. And in the preterm baby, the nadir comes early, and the nadir is more there because preterm, the systems, due to certain reason, they are slightly insensitive to the hypoxemia. And in preterm babies, there is a switch of hematopoiesis from the liver to bone marrow, which is happening. The one question actually answer which was remaining was that if the exchange transfusion is needed in ABO, so the blood should be used of the blood which is compatible with both mother and the baby. Because suppose mother is O positive and baby is A positive, then anti-A has already been given to the baby. So you should if you will transfuse with A positive blood, then there is a chance that you may increase the amount of hemolysis. So ideal will be to use the mother's blood, that is the O positive. So if there is mother is O and baby is A or B, then you will use O positive. If the mother is A and baby is B, then you go with the baby blood group, that is B positive.
Or we can take O blood cell, pack cells, blood RBCs, and AB
In the
plasma.
plasma. Yeah, yeah. Dr. Ravi, the next question
Yeah.
is, what is the significance of high monocytes and eosinophils in neonatology and its management?
What is the significance of high monocytes?
Yeah.
I don't think so. Individually they has got any significance as compared to the older children. They have got eosinophils. They have got a different interpretation, and monocyte they have a different interpretation. But as far as neonatology is concerned, they do not have an isolated significance. So they should not be interpreted in silos. They should not be interpreted as an individual. Because the sepsis screening and the part of other they are the actually the group of investigation or the component of the screening. So that actually signifies in isolated monocytes and eosinophils has got no significance.
Can I just add one thing, Ravi?
Yeah,
Yeah,
please go ahead, Dr. Prashant.
Yeah. So, I mean, as rightly said, it is not individually significant, but mainly if we see monocytes increases in general due to some infection or inflammation, may it be in neonates or elder children. It may be a viral or bacterial infection, but what we usually see is monocytes are usually increased in case of congenital infections, right, Ravi? Like the
Yeah, of
toxoplasma
course.
papilla and all this. That will be one clue that if you are suspecting a congenital infections, then in
Yeah.
that cases monocytes will be high. And eosinophils like allergic conditions or any other things which can be there in which this will be increased. Uh, Apart from that, I don't think what you said is correct, that we don't see any other significant of that things.
Means isolated these increase in the cells has no significance other than we are correlating clinically something significant.
Yeah, yeah. Another question is role of IVIG in RH incompatibility. So,
Dr. Prashant, would you like to add something? What's your opinion
Yeah,
about?
fine. So role of IVIG, it depends. Again, there are guidelines that according to the level of the hemoglobins, usually we are going for the RH isoimmunization treatments. In milder cases, yes, there is a role of IVIG because that is preventing the hemolysis. So that can be given 1 to 2 gram per kg can be given to a newborns. So that is there.
yeah.
So
So,
as far as
sorry.
Doctor, as far as evidence is concerned, the recently the Cochrane reviews has also come, and the meta-analysis also shows that the role of IVIG is not there in case of RH incompatibility. So it was earlier thought of that that it is going to to prevent extent transfusion. So as of now, the study says the recently the CPG guidelines by NNF is also stating that the IVIG has got no significant role in RH incompatibility. I think Dr. Akash has already joined. Dr. Akash, you are muted now. So because
Hello.
you were offline for some time, so therefore we have answered some of the question. But as of now, we are discussing the role of IVIG in RH incompatibility. What is your take on this, Dr. Akash? Can you hear me, Dr. Akash?
Hello.
Dr. Akash, can you hear me? Hello? I think still there is some audio
Hello.
issue. Dr. Akash, can you hear me?
Yes, sir. Audible.
Yeah. Okay.
Am I audible, sir?
Yeah,
Yes,
yeah,
yes.
you are audible. You are audible, but we are audible or not?
Yes, sir. Now audible. Sorry
Okay,
for some.
Dr. Akash, we are discussing here the role of IVIG in RH incompatibilities. What is your take on this?
5 minutes में call back करूं?
We usually do not use IVIG because there is hardly any evidence, and IVIG as such is associated with some related complications, including anaphylaxis and the cost also. Although there is some evidence, the recent meta-analysis which was uh, done by Dr. Deepak Lois from the Canada showed there is some evidence in ABO incompatibility, but RH incompatibility definitely no. And with the now advent of the excellent phototherapies we have, I think the incidence of doing an exchange transfusion is dramatically decreased.
Okay. Dr. Naveen, what is your take on this? Your opinion?
Yeah. So I think as stated earlier that there is a doubtful role although the AAP guidelines in cases of jaundice, if there is RH incompatibility and DCT is positive. So DCT positive means there is isoimmune hemolysis going on. So important is that we should not just go by that mother is RH negative, baby is RH positive. First, do the DCT and make sure that there is isoimmune hemolysis going on. And the indirect Coombs test in the mother will also be an indicative towards that. So if DCT is positive and bilirubin is falling near exchange range, then of course you are giving phototherapy. But in addition to that, you can give intravenous immunoglobulin 1 gram per kilo, 2 doses, 12 hours apart. So although as stated by Dr. Akash and Dr. Ravi that there is no such clear-cut role, but still based on those guidelines, which are mainly the expert based guidelines, there are units which are giving IVIG. The important thing to remember is that IVIG does not have any role in sepsis. And in case of RH incompatibility, you first should look at that DCT is positive or not. One person has also asked the question, very relevant.
Does the recent AAP which came last year also suggest giving IVIG, sir?
I am
Because
not
the recent updated version.
I'm not 100% sure, but I think so.
No, as far as the AAP is concerned and NNF is concerned, CPG guidelines also shows that the IVIG has got no role
Okay.
in management of RH incompatibility. Though earlier it was considered that there is some role in preventing the exchange transfusion. But as of now, the statement the NNF CPG guidelines says it has got no role.
Okay.
I'm particularly quoting about the NNF CPG guidelines in American Academy of Pediatrics.
Okay, perfectly fine. Perfectly fine. So it's okay.
Yeah, Dr. Naveen, please go ahead.
Yeah. So where were we? I think somebody asked the question, what is the difference between RH incompatibility and RH setting? So same which I explained, Dr. Akash, that
True, sir. That is just setting does not mean that it is an RH income.
hemolysis,
Only
right?
if DCT is positive, then it is a cause of concern. Otherwise, just mere presence of negative blood group in the mother and positive blood group in the baby does not imply it is RH incompatibility.
Yeah. Can FFP be used in 2 or 3 aliquots from a single FFP pack, Dr. Akash?
Usually, what the guidelines say, if you have usually the FFP is stored at -18. So if you have thawed it, it is then known as thawed plasma. For thawed plasma can be stored at 1 to 6 degree for 24 hours. But again, if you are taking part of the FFP from the bag, then contamination is a high risk. Ideally, should not be used.
It can be actually said to a blood bank. It can be said to a blood bank to have 2 or 3 aliquots, different aliquots preserved if you are suspecting that you are going to repeat the FFP transfusions. So if blood bank is giving separate aliquots, then it can be used, right, Dr. Akash?
True, sir. Pentabags can be used both for PRBCs as well as for plasma. Agreed.
So the important message is that once it is thawed, it cannot be done back. So if the blood bank is issuing you whatever bag, you use it at that point. So what is the difference dose of platelet transfusion, Dr. Akash?
10 to 15 ml per kg over 1 hour.
Over 1 hour. Right.
And during transfusion, also keep agitating the bag.
We got African baby already pre-transfused with pancytopenia. Does races also affect the management?
I'm not aware of any such difference.
Yeah. So same. I mean, we don't know that how much epigenetics play in this, but okay. Role of IVIG in ABO incompatibility, I think that has been answered. Sir, kindly throw some light on polycythemia when do exchange transfusion.
So again, I thought polycythemia is one of the easiest topics, so I did not cover it. So polycythemia, usually we defined if the hematocrit is more than 65. If it is more than 65 venous hematocrit with symptoms, then you can do exchange transfusion. Again, there is controversy that partial exchange does not make a difference in long-term neurological outcome or any clinical outcomes. Or if the hematocrit is more than 70, baby symptomatic, for example, hypoglycemia, jaundice, hypocalcemia, you may think of doing partial exchange. But again, there are two school of thoughts which are in favor of partial exchange, the other believes in more conservative approach. Your thoughts?
Yeah, I 100% agree with you, Akash, that polycythemia, although the easiest topic, but most debatable one, because the doing the partial exchange does not change the long-term neurodevelopmental outcome, whatever data we have. So, majority of the practice guideline will suggest symptomatic more than 65, you intervene, and asymptomatic more than 75. In few reports, there is increased monocytes in DLC report like 12%. What is the significance in the newborn?
Monocytes usually they are not do not carry any significance, and except in the case of infectious mononucleosis, or sometimes these fractions also change depending on the drugs you are using, especially the antibiotics. So it does not carry any significance.
Yeah. So, Akash, I was sorry to interrupt. I was just going through the AAP guidelines 2022, which suggests that IVIG can be provided to babies with isoimmune hemolytic disease whose TSB reaches or exceed the escalation of the care threshold. Although they have written the thing which you are saying, that the potential benefit of IVIG is unclear. So
Again,
they are writing that benefits of IVIG are most likely to exceed the risk in newborns with isoimmune hemolytic disease and TSB that has exceeded the escalation of the care threshold and is rising despite intensive phototherapy. So I think the first point is, as per those guidelines, first point is that important is that DCT should be positive. First is, so you document that it's an isoimmune hemolytic disease. Second is, if your phototherapy is failing, like in spite of your intensive phototherapy, your bilirubin is rising despite beyond that, and you are thinking that this baby will land up in exchange transfusion. So there the role of IVIG may be there. But yes, there are question marks to it. It's not such a clear-cut evidence-based statement.
This is some way.
some units also use it post exchange to prevent another exchange.
Yeah.
So still more powered studies need to be required
Yeah.
to arrive a conclusion.
Yeah. So, right. So, there is one question from Mr. Virender Verma. Could you please throw a light on platelet indices and their role in neonatal pathogenesis, especially an early indicator of sepsis, like platelet count, mean platelet volume, platelet crate, and width of distribution? Excellent.
Mean platelet volume we have already discussed. Just like there is a significance of red count in anemia, mean platelet volume, if it is increased, it tells us it is either increased consumption. If it is decreased, then it tells us it is because of the production of the failure. Similarly, platelet count as such, as I already highlighted, that platelet count as such does not tell us about presence or absence of sepsis in isolation. As we discussed, that platelet count can be low even in normal baby just because of the placental insufficiency. So in isolation, thrombocytopenia is not a marker of sepsis.
Great. So, what is the cutoff value of hematocrit for polycythemia discussed? Is blood group determined in neonate is final, or it has to be confirmed again later on? If yes, at what age? Excellent question.
Usually, sometimes there can be a risk of contamination if you are doing this blood group from cord sample. But if you are taking a neonatal sample, you don't need to repeat again.
Yeah. Although majority of the blood banks, majority of the path labs at least in Delhi, they always recommend that you have to repeat it at 3 to 6 months. But as Dr. Akash rightly said, that there is no need if you are doing it from the baby.
That may be done only in cases where baby has received intrauterine transfusion.
Right. So, Dr. Baljit is asking thrombocytopenia in Down syndrome.
Thrombocytopenia, actually, usually Down syndromes are pancytopenia and myelodysplastic syndrome, where thrombocytopenia is part of it, and usually it is severe and persists for long.
Yeah. So question is, sir, please repeat about the exchange transfusion plasma and RBCs. So this was the thing Dr. Pankaj was saying, Dr. Kartika, that so when your baby needs exchange transfusion, you have two options. Either you do with the whole blood or you do with the plasma and RBC. The good thing about, suppose, let's assume that the mother is O negative and baby is A positive. So now which blood will you choose? You will likely to choose O negative packed cell, right? Because negative positive, you have to choose the negative because NTD already are there in the baby. And O and A, you have to choose O. So you will choose O negative red blood cell and you will choose AB plasma because AB plasma will not contain any of the antibodies. So you are giving the blood which does not contain any antibody and any antigen which will be killed by the any antibodies which is there in the baby. So O negative packed cell and AB plasma. And how do you mix it? 8 ml of O negative packed cell roughly with the 2 ml of AB plasma. So in 10 ml, this should be the ratio. Ratio should be 80 to 20. However, the ratio you can determine if you have the hematocrit of the packed cells what you are transfusing. If you can check that, so based on that you can, and based on your target hematocrit, you can adjust this ratio, but practically this ratio comes around 80 to 20.
Because this is the most confusing part, among the postgraduate.
We usually use a 3-way and 3:1. 7 ml of 7 ml of PRBC and 3 ml of plasma.
3, yeah. So 7 is, people use 7 to 3, some people use 8:2 with the 3-way, as Dr. Akash rightly said. But if you can, if you know about the hematocrit of the packed cell you are transfusing, you can easily adjust the ratio. Yeah. So Dr. Rishibai is asking, spherocytes seen in peripheral blood film, important causes other than hereditary spherocytes. What age generally hereditary spherocytes present?
Again, so other important cause of spherocytosis in peripheral blood film is the commonest is ABO incompatibility. Again, hereditary spherocytosis usually is not diagnosed at birth unless and until you do a genetic analysis. What at birth you can do is send a CBC of the parents and test the parents. Usually we test for spherocytosis at around 6 months, 4 to 6 months with flow cytometry.
Yeah. The another question is how to investigate low reticulocyte count.
As I said, that low retic count can be is because of the marrow failure, which if baby is otherwise fine, can be because of the placenta insufficiency. However, if it is prolonged and is inappropriate, look for congenital marrow failure syndromes.
Yeah. I think the many time in preterm babies also low reticulocyte count indicates that the erythropoiesis has not started. So even in the stable preterm babies, you transfuse at a hemoglobin of less than 7. You also take into account the absolute reticulocytopenia or the low reticulocyte count. That means the erythropoiesis has not started. If the reticulocyte count in that situation is high, so sometime you may get away without transfusion because thinking that erythropoiesis has started, and if you provide the baby with the adequate substrate, that is the iron, you may get away without the transfusion. In volume overload condition, especially with sepsis in ARF with thrombocytopenia and coagulopathy, can we give the platelet and FFP in the recommended doses or should the volume be lowered?
No, it has to be given in the recommended doses. We do not have to decrease the dose. Do not give excess, but do give the recommended dose.
Yeah. Is there any better test than DCT for confirming isoimmune hemolysis if in dilemma?
I'm not aware of any such test.
Yeah, I think this is the best test, Dr. Amit. And the baby, in hemolysis, if it is going on, the hemoglobin will be lower. You can do the serial hemoglobin, it will be lowering down. Although in ABO, if the DCT is positive, you will not see the fall in hemoglobin. But yes, DCT is the best one. But sometimes if the hemoglobin is very, very low, suppose the baby is having a hemoglobin of 4 and it's a hydropic baby, the DCT can be falsely negative also. Kartika Nair, drug causing thrombocytopenia, very wide.
And say it's almost all antibiotics which we use in day-to-day life.
Yeah. Increased monocytes, I think this has been discussed in detail, that what is the significance of increased monocytes in neonates. Role of procalcitonin, septic question. I think this will be an endless question. So,
and it was discussed in earlier, classes.
Yeah. If the hematocrit is 70% and baby is asymptomatic, whether to go exchange or not. We discussed asymptomatic, yeah, asymptomatic 75, symptomatic 65. Can ITP occur in the neonate? Dr. Manoj is asking.
Neonatal autoimmune thrombocytopenia, we discussed that if mother is having ITP, the antibodies can transfer to the babies and can cause thrombocytopenia.
Yeah.
So it will be only transient and self-recovery will occur.
Majority of the self-recovery, but we have to keep a watch on the platelets. If the platelet goes below 30,000, we give IVIG.
Yeah. Okay. I think that's all to the questions, and thank you very much, Dr. Akash, for taking the questions so nicely and for such a lucid presentation. Over to Dr. Ajay.
Once again, I thank Dr. Naveen, Dr. Prashant, Dr. Akash, Dr. Ravi, and Dr. Pankaj Garg for joining us for this wonderful session. Dr. Ravi, would you like to say something?
No, thank you, sir, for opportunity. And Akash has already elaborated in such a comprehensive manner. And this is the icing on cake by moderated by the Dr. Naveen. It's already, I think, very well elaborated. And over to you, sir. Nothing else.
Okay, thank you very much. So I thank all the delegates once again for joining, and we'll be here again next Sunday at 9 o'clock. Please be there at 9 o'clock because we start sharp at 9 o'clock.
Thank you.
Thank you so much.
Thank you so
Bye
much, sir.
bye.
Thank you, sir.
Right.
Mr. Sushil, please close the session. Mr. Sushil?